So, good evening, everyone. I am Dr. Sanket Nivale, representing medical affairs at MCure Pharmaceuticals. I welcome each and everyone to the No Thrombosis workshop series in acute ischemic stroke. To introduce our faculties today, our course director, can I have the next slide, please? Our course director, Dr. Subhash Kaul, sir. Sir is a senior consultant and stroke specialist at KIMS Hospital, Sikandrabad, and chairman and KIMS Foundation and Research Center. He is a faculty for 27 years at Nizam's Institute of Medical Sciences, Hyderabad, former professor and head Department of Neurology and dean at NIMS. 120 publications in national and international journals. He's been the principal and the co-investigator of several national and international projects, including the largest single center Hyderabad Stroke Registry, funded by ICMR. State Teacher Award by Telangana government in 2017. Past President AP Neuroscientist Association, past president of the Indian Stroke Association, and past president of the Indian Academy of Neurology. Next slide, please. Our moderator for the evening today would be Dr. Saurabh Subhash Chandra Bilala. Sir is a consultant neurologist, Bilala Hospital, Akola. He has done his DNB neurology with 3 years comprehensive course in neurology under the guidance of Dr. Noshin Wadia and Dr. S.M. Katrak and Dr. Joy Desai, sir, with exposure in general neurology, epilepsy clinic, movement disorders, and stroke care. Done presentations at the medical and surgical treatment outcomes in mesial temporal lobe epilepsy in Econ 2010 at Indore. We welcome you for the event, sir. Next slide, please. Our speaker for today would be Dr. Shailesh Mohan Badore. Sir is a consultant neurophysician at Rush Super Speciality Hospital, Hyderabad. Skilled in handling all neurological emergencies and elective cases, including stroke, epilepsy, movement disorders, and neuromuscular disorders. Extensively trained in routine and special neurology examinations and interventions. Presented multiple papers and posters at national conferences. Sir, we welcome you for the event. Can I have the next slide, please? Our second speaker for today would be Dr. Vishal Savali. Sir is a consultant neurologist at Wokhart Hospital, Nasik. He is also a consultant neurologist at Neuro Plus Brain and Spine at Nasik. He holds an experience of 7 years in the medical field, and he has done multiple research and case reports publications in reputed journals. Sir, we welcome you for the event. And now I would like to hand over the session to our course director, Dr. Subhash Kaul, sir, for his opening remarks. Open to you, sir.
Yeah, thank you very much, Dr. Savali. This is, I think, one of the very important forums in which we meet once a month and discuss about the individual patients of stroke. As Mr. Fisher has said, neurologists learn neurology stroke by stroke. We learn stroke also stroke by stroke. Each patient gives you some new insight, some new picture, some new problem, some new dilemma. At the same time, we have to tackle it. And this we will not learn in clinical trials or randomized case series and all this. You learn by individual case. This is a very good forum where we are meeting once a month. And so I will welcome all of you. And it's my pleasure to hand over to the moderator for today, Saurabh Subhash Chandra Bilala. We share our name also. Mine is only Subhash. Saurabh Subhash Chandra Bilala. I welcome you, Saurabh.
I'm here, sir. Good evening.
Hello, good evening.
Yeah.
And you can invite our first speaker, and after that we can have discussion. I think we'll have discussion at the end of each case individually. If there are any questions from audience, Saurabh, please carry on. Please invite the first.
Yes, sir. I will.
Shailesh. Hello,
I will
Shailesh.
share the file.
You have already been introduced. Go ahead with your case.
Yeah. Good evening, everyone. Today I am presenting one case scenario. Am I audible?
Yes, sir. Yes, you are.
Yeah.
You're audible.
Yeah. This is a 24-year young male. He presented to our ER at 7:30 a.m. on 10th of June 2022. He presented with history of giddiness and nausea since 2 days and generalized weakness and lightheadedness. And there was one episode of vomiting on the day of admission morning. And there was one history of giddiness and double vision in June 2020. During that time, the MRI was suggestive of no acute infarct, but there were multiple old infarcts in bilateral cerebellar region. And patient is alcoholic, and there was no history of any diabetes or hypertension. On examination, vitals were stable, pulse was regular 90 per minute, temperature was normal, BP was 130 by 80. On general examination, there was no significant finding. On CNS examination, he was conscious, oriented to time, place, and person, and power was normal in all four limbs. And sensory examination was normal. Deep tendon reflexes were normal, and there was horizontal nystagmus on both sides, and ataxia was present, and Romberg sign was present, and there was no other cerebellar signs like dysdiadochokinesia or intention tremor. On presentation, MRI was suggestive of subacute infarct on the right occipital region. It was also visible on flare, and on the brainstem, it was reported as initially normal, and there were previous bilateral cerebellar infarct. And angio was normal, only PCOM was slightly hypoplastic. This was the MRI which was reported by our radiologist. Subacute infarct involving right PCA and MCA PCA borderline zone. There were no acute infarct, and focal gliosis was there in bilateral cerebellum. Subsequently, patient was shifted to ICU, but after shifting, his speech deteriorated suddenly, and the right upper limb and lower limb power also deteriorated to 1/5. Hence, the MRI was repeated immediately, and it showed left pontine acute infarct with ADC reversal. And in a sagittal diffusion weighted image, there was clear-cut pontine infarct, and it was reported as hyperacute infarct in the left pons. So in view of NIHS of 13 and deterioration in power in right upper and lower limb, as patient was in window period, as there was new neurodeficit, patient was thought of he was in window period, and he was thrombolized with tenecteplase, and subsequently next day CT scan was repeated, and there was no bleed, and he was started on antiplatelet, and he was continued on statin, and on discharge after 5 days his power improved to upper limb 2/5 and lower limb 3/5, and speech was also significantly improved, and NIHS improved to 9/42, and during hospitalization all stroke workup were done, 2D echo, carotid Doppler, ANA profile, prothrombotic profile, HB electrophoresis, Holter monitoring, everything was normal. On follow-up after 1 month, patient was able to walk without support, and NIHS improved to 5/42. So this was a learning point. Initially, we thought that patient maybe whether it was alcohol-related ataxia and giddiness as patient, and there was one significant personal history which I did not mention in the case scenario. He had recent breakup with her girlfriend, and there was sudden acute binge of alcohol. So initially we thought of whether it was alcohol related ataxia and giddiness, but as patient power significantly deteriorate after hospitalization, and which was required thrombolysis, and it was luck that he improved after thrombolysis. So from these are some condition which were mimicking acute ischemic stroke like hypoglycemia, alcohol, hyponatremia, drug-induced or psychogenic, seizure, complex migraine, or any hypertensive crisis or Bell's palsy. So we have to see the first criteria: face, any deviation of face, any arm weakness, any speech difficulty, and immediately we have to act. So these are the inclusive criteria for thrombolysis. The main criteria for thrombolysis is CT or MRI should be negative for hemorrhage, and patient should be in window period, and there should not be any previous major surgery or any bleed in the past, and relative contraindication or others are all relative contraindication. So we have reviewed the literature. There was one paper published in Frontiers in Neurology on February 2020, identifying gaps and missed opportunities for IV thrombolysis treatment in patient of stroke. So in this study, there were 87 people were eligible for thrombolysis but could not be thrombolized. Only three people out of 87 were thrombolized. In that, they have given these causes why it was not thrombolized. Poor functional status, baseline neurodeficit, suspected complex migraine, witness cardiac arrest, suspected somatic symptom, rapidly resolving symptom, abnormal BP or blood sugar level, then witness seizure, then suspected metabolic encephalopathy, and low NIHs, and other causes like cardiogenic syncope, then any non-compressible side bleeding, acute ischemic stroke within 3 months, intraaxial tumor or established infarct on CT scan, major surgery within 3 months, prior IC bleed, out of treatment window period patient, and unknown last seen normal coagulopathy. So take home message, new neurodeficit should not be neglected. Patient can be thrombolized if there is deterioration in symptom as compared to previous neurodeficit. So, and one more point I want to stress, when we go back to the previous scan, the first scan, there was very one subtle left pontine infarct. So we thought that maybe we have missed previously, but patient as he deteriorated, then it was luckily he improved after thrombolysis, and we have thrombolized, we have taken proper decision or not, but patient was benefited. Thank you.
Okay. So I just wanted to some clarification.
Yes, sir.
When the patient came to hospital, at that time he had only symptom of vertigo or
Yes,
ataxia.
Sir. Yes, sir. Giddiness, and on examination ataxia was there, sir.
And I mean the history was for the last 2 days, right?
Yes, sir.
2 days history, and then MRI was showing this subtle thing at
Yes,
the time
sir.
which you showed.
Initially, it was reported as normal by the radiologist. There was no acute infarct, only subacute infarct in the right occipital region. That was mentioned. Yes, sir.
And now you did his new MRI when he had deterioration, right?
Yes, sir. Yes.
And what was the deterioration? What was the deterioration?
This, sir, speech deteriorated, and right upper limb and lower limb power also deteriorated, sir. 1/5. NIHS was 13, sir, that time.
But it was in continuation with the symptoms which had started 2 days.
Yes, sir. Yes, sir.
And radiologically, it was exactly in the same place.
Yes, sir.
So,
retrospectively, when we saw it, then it was seen, sir.
So I think there is a very big message in this.
Yes, yes. That's why I take this. That's why I took this for presentation.
Yeah.
Because it is dilemma in this case.
Yeah. I mean, it's interesting, and it's good that you brought it up, because that's how we learn. Now, this is something which will not be in any book. And
Yes,
this
sir.
is something which you will never be allowed to thrombolyze actually in this situation. I'll tell you why.
Yes, sir. Yes, sir.
One is that one of the criteria is that if you have had an old stroke within 3
Yes, sir.
months,
Yes, sir.
then you should not thrombolyze. We had an old stroke, but we don't know what was the duration of that occipital lobe.
Yes, sir. Yes, sir.
So we can assume maybe it was beyond 3 months, and so that's okay.
Yes,
But
sir.
as far as this particular stroke is concerned, obviously, now that we see this was a progressing stroke, which had
Yes, sir.
started 2 days back. He had ataxia.
Yes,
And
sir.
why it was a progressing stroke? Because our new stroke is exactly in the same location. The same thing what you are seeing retrospectively.
Yes, sir.
Same place has become a little more. That means there must have been some collateral flow maintained, because of which his deficit was not then. Then at some point that collateral failed and he became densely
Yes, sir.
ataxic and all that thing. Now,
Yes,
normally we would not be allowed to thrombolyze this patient, but you did thrombolyze and the outcome was good.
Yes,
So
sir.
that,
Yes, sir.
so that means, I mean, even now also, if you were sure if you had picked up that retrospective thing before only, it might have put you in a dilemma. You might not have thrombolized.
Yes, sir. Yes, sir.
So that means so the message is that, even after we think window is closed, window may not be closed.
Yes, sir.
It may be still open, and we are not thrombolizing just to be on the safer side. That is why the latest thing says that you can even thrombolize up to 24 hours also. But they say that you should do those perfusion, diffusion studies and all that thing, which are not possible every time. But I think it's a great learning. Thank you very much. I think Dr. Bilala can give his comments, and maybe Vishal can.
And sir, during our medicine residency, our physician, they used to say if there is persistent chest pain in cardiac patient, better to go for thrombolysis. Like that in stroke patient, if patient is deteriorating, then I think we should intervene.
Sir,
if there is any new neurodeficit.
Very interesting case.
Yeah.
Only, and the confounding factor on history, when you see there is alcohol is a confounding factor, then the personal life is a confounding factor. So this make us go against thrombolysis.
Yes, sir.
If we are like conservative in our approach, the deficit is not that severe. He has a binge, and this is some symptoms. So we try to avoid. This might be not much more related to stroke.
Yeah. That was the initial problem. We thought due to this breakup and alcohol binge, he is developing this symptom, and we neglected the initial scan.
Yes.
And luckily we picked up in the second scan, and after thrombolysis he improved.
Yes.
By luck.
And that NIHS score is also less, 2, 3, and then you think alcohol is there. There is an emotional overlay. Young male. Why a young male should have a stroke?
Yes, sir. And one positive history was 2 years back he had giddiness and double vision. That also. That time also there was no acute infarct, only some old infarcts were there, sir, that time.
Okay.
Maybe that was also significant, but because of alcohol and this private life issue, we thought that patient is malingering like that.
Yes. Yeah. Good case.
Yeah, sir. Thank you.
So any other comment from the audience? No, I think.
Yes, sir. First is better not to rely on the report of radiology.
Yeah.
Because first report, I think if we see closely, more cuts from brainstem and diffusion restriction or that ADC, we may be able to see some part of some hypodensity and some part that brainstem is affected, and it is correlating with the ataxia. It is correlating with the ataxia.
Yes,
So
yes.
first and most important, don't rely on the final reporting of the radiologist. It's always better to see the films.
I completely agree. I completely agree with you. In my whole life, I have committed mistakes. I have seen others committing mistakes.
Yes.
So our best friend is ourselves, you know.
Correct.
And you listen to others. Check the radiologist report also. Too much overconfidence is also not good. Look at the radiologist report. Sometimes he may pick something which we have missed. But at the same time, check each and everything which he has said. You know, on the other hand, I remember when TPA was first came, and that was 2003, 2004, around at that time. I have seen one patient who was thrombolyzed, and his CT scan was done. MRI was not done. It was normal. CT will be normal in acute infarct. And he was ataxic. He was something like your patient. He was ataxic. And the old man, hypertensive, so the resident had thought that it was from another hospital. I was asked to just give an opinion. So I went there. And CT was normal and he was ataxic. And he recovered actually by next day morning. But during history taking, it turned out that he had consumed some 10-15 tablets of some compose or something, some sedative. And that is what had caused ataxia and drowsiness. And he was thrombolyzed also, you know, because in CT scan, you don't look for an infarct. CT scan can be normal. But I didn't tell anybody. But I only told the doctor that, look, this is the thing. He was probably drug-induced ataxia. You have thrombolyzed him, no problem. He said yes. And after 2 weeks, the same patient was again brought to the same hospital. That time he was not thrombolyzed. And they just checked his drug bottle. Again, it was empty. And that day also he had taken those 12 tablets or something. So it is very important to check all this. But you know, this radiology point is so true. I have seen intracerebral hemorrhage being thrombolyzed.
Oh my God.
And why? Why? Because it was small hemorrhage. And a small hemorrhage, sometimes, if you look only at diffusion, it looks bright. Only thing is that it may be little bit heterogeneity, but if you look at superficially, it will look bright spot. And we are so much biased towards ischemic stroke. And this was thrombolyzed, and he had a bleed, and he was brought to me for complication. But then, when I looked at everything, I was because if you look carefully in GRE, so whenever we look at diffusion, we must look at GRE sequence also. We must look at ADC. But GRE is a must. Always we should make it a point to look at GRE. We should look at flare. We should look at T1. We should look at T2 and convince ourselves it is indeed an infarct. Because rarely even an acute, hyperacute infarct may mimic a bleed. Yes. So those are the lessons. Basically, I'm repeating what you said, Dr. Vishal, that we should be good in stroke radiology and things.
Correct.
But it was a great case. It was a great case. Good original learning from this.
Yes. And second point, not to bring girlfriend in between.
Yeah.
Sir, I want to ask you whether any new neurodeficit or worsening of symptom, whether we should thrombolyze such case or not. Sir, your voice is not clear, sir.
As per the current available literature, what is recommended is that you have to know when did this particular stroke start. As per our guidelines, MRI is not required. So forget about imaging. Don't give too much of importance to flare imaging. That is our own invention. As per the guidelines, all you need is a CT scan. If your CT scan is normal, and once the deficit has started, so you have to only know when has the deficit started. If your deficit has started more than 4.5 hours and your person is worsening at 8 hours, 9 hours, then normally you should not give IV TPA unless you can do diffusion, perfusion imaging and show that there's a mismatch and all, then you can give. But otherwise, everything depends on, if you don't have that new technology of perfusion imaging, you have to know when has the deficit started. So if your patient has worsening after 3 hours, don't worry, you give it. He's still within window. If your person is worsened at 4 hours from the onset, you go. If your patient has worsened even at 4.5 hours, don't worry, give it. But if your patient has worsened at 8 hours, then you cannot give. You can give it if you show diffusion, perfusion, mismatch and all that. Then you can give it, but not otherwise. But on the other hand, if your patient has become completely normal, I mean, if it was like a TIA, then you don't worry. Then your worsening is a new attack because he had become completely normal first. So this is the important thing. If it is progression, then you have to take the stroke onset from the beginning. If it is complete recovery, then you can take it as a second attack. Okay, sir. Thank you. Next. Thank you very much. Thank you very much. I think we can go to the second page.
Yes, sir. Good evening. Slides are visible, sir?
Yeah.
Yeah. Good evening. I'll just share one experience, unusual presentation of rare etiology. I'm Dr. Vishal Savali. I'm a consultant neurology at Okhad Hospital and my own clinic NeuroPlus at Nashik. So this is a young female patient, 38-year-old female patient without any comorbidity. She presented with acute onset left side hemiplegia, complete hemiplegia, power was almost zero, severe dysarthria, slurring of speech was there. There is no history of any loss of consciousness, vomiting, or any seizure episode, or history of headache, or any drug intake. She presented to us within 1 hour. On examination, she was conscious and oriented. She has complete left side hemiplegia, left-sided facial paralysis. Power in upper and lower limb in left side was 0/5, NHS around 14. Vitals, blood pressure was almost 150/90, pulse rate 84 regular, SpO2 normal, random blood sugar was 130. So we have code white here, we activated and we did some vitals and some routine investigation was sent, and we take the patient immediately to the MRI. We have facilities on our toes, means nearby only emergency. So instead of CT scan, we did MRI, and in MRI there was a right hemispheric infarct with MCA cutoff. As we can see here, right MCA was cut off. There is complete blockage, and in this patient, before going, we have two options. Either directly go for MT or IVT, but I usually prefer IVT first before going to MT. So we decided to thrombolyze this patient. There was no contraindication. Blood sugar, blood pressure, everything was okay, and we didn't find any contraindication for thrombolysis. So we thrombolized this patient with injection altiplase, 0.9 milligram per kg body weight, 10% bolus was given, and 90% over 1 hour. Patient was assessed every 15 minutes, and within next 30 minutes, patient shows miraculously improvement. The power, which was almost 0/5, which was means after 30 minutes only, it was 4+/5 in both upper and lower limb. Facial also improved, speech also improved. I'll show her video after improvement.
डावा हात वरती उचला.
Can you see video, ma'am?
दात दाखवा.
No.
हात कुठपर्यंत जातो वरती.
You have to share the close
Yes.
this and share it. Yeah, visible now.
डावा हात वरती उचला.
So this was improved after 30 minutes.
ओके, पूर्ण
Facial
हात
also
वरती उचला.
improved.
पूर्ण हात कुठपर्यंत जातो वरती.
The power which was 0 after 30 minutes, she showed almost complete recovery on left side. So after thrombolysis, she improved. So we did a repeat MRI angio, and it was almost completely recanalized. So the right MC, which was blocked, it was showing flow, and peripheral blood vessels also visible. So can we call it as a medical thrombectomy? Should we call it a medical thrombectomy? So we don't know the cause. What was the cause? So we investigated. This picture definitely gives a clue. His right hand was pale as compared to the left. Can anyone guess what will be the etiology for this patient?
Any dissection of aorta?
Hello.
Any aortic dissection?
Okay, one of the possibility, but there is no history of severe headache, severe neck pain, anything, or chest pain. Patient was completely conscious, oriented, without any symptoms, except left side hemiplegia and facial deviation.
Subclavian still.
Subclavian still okay. Subclavian still means dislodgement or of thrombus, which can block carotid or MCA. Okay, we found actually a rare that there was the extra cervical rib which was compromising the vasculature. The subclavian, entire subclavian artery on the right side was blocked, as well as there was a thrombus at the bifurcation of carotid, which was dislodged and which got stuck in MCA. So this was the case which presented to us with a rare etiology that thoracic outlet syndrome can also present as a first symptom of left side hemiplegia or stroke, CVA. So I just want to highlight that thoracic outlet syndrome was a rare possibility of stroke. This can be kept in mind. Later on, the cervical rib and the thrombus, the entire subclavian, was removed by a vascular surgeon, and cardiothoracic surgeon has removed that extra rib. She is under follow-up now. She is doing well and on oral anticoagulant.
Any carotid Doppler was done?
Sir?
Carotid Doppler.
Yeah, carotid Doppler. There was a large thrombus which was extending from the carotid bifurcation, also from the subclavian artery till the brachial artery. Brachial artery also was poorly palpable. Only radial pulse was there, but it was feeble as compared to the left. But there was no symptom of any vascular compromisation in right hand or any other symptom, pain, tingling, anything. This was the first symptom as a presentation.
Did you see the literature? Have such cases been reported before?
No, sir. I have searched thoracic outlet syndrome, extracervical rib, not yet reported, sir. The thrombus was very extensive. It was extended up till bifurcation of the carotid and entire subclavian artery.
But there was evidence of compression of the carotid artery by the rib, because normally when we talk of thoracic outlet, we talk of subclavian artery only.
Yes,
But
sir.
in your case, it is the carotid. But was there evidence of radiological evidence of compression of the
No,
carotid
sir.
artery?
Sir, angio, I have shown to you, the angio doesn't show any carotid compromisation.
So then what we have to think is that maybe the basic thrombus was happened in the subclavian artery, and from there it extended retrogradely and went into the carotid.
Yes, sir. Yes, sir. That's the only possibility. The dislodgement of the thrombus and which stuck in the bifurcation of the carotid, which again went up and blocked the MCA.
Yeah, because patient does not have at all any other risk factor like high homocysteine or
Yes. We have
any.
evaluated further ANA, vascular profile, hypercoagulous state, everything came negative.
Very, very rare. Very rare. I'm seeing for the first time. Very, very nice one.
That is the only possibility that the thrombus has dislodged from the subclavian and it went up.
And yeah, correct. Because you have thrombus in subclavian also. That means it is there.
Yes, yes.
Very good. So did you do all her investigation? But still, you should have done. I mean, you must have done.
Everything, cardiological, hypercoagulous state, vasculitic, everything. Young stroke. We have rated as a young stroke, and all came negative, sir.
And the other interesting thing in this patient is that even though it's a large artery disease, it responded well to intravenous thrombolysis. And that is one of the reasons why we should always attempt intravenous thrombolysis, because in almost 30% of the patients, intravenous thrombolysis can dissolve the large artery clots. I have also seen.
Yes, sir.
So
and
in
the
that
time
case,
duration was also only 1 hour. Within 1 hour, they came to emergency, and
because in that case they are spared the cost and the risks and all of mechanical problems.
Yes.
So this is one of the arguments given in favor of bridging. That you should give patient a chance and a choice of IVT even when we are contemplating. It's a very important point, and your case is very nicely showing that. In fact, I remember we had a similar case once, and I was traveling, and another patient came, and our interventionist also was traveling, and we had only one interventionist, and we said what to do. Then I told them, okay, you just give IV thrombolysis. Patient recovered completely. So this can happen, but it won't happen in all. Even after that, you have to do a check angio and see. But some patients will recover. That's very nice.
Yes.
And yeah, you have done TEE also in this patient. That also you have to, because patient is young, you have to do patent foramen and ovale and all that.
I didn't get you, sir.
I'm saying, even though there is an obvious cause, but because patient is young, we should also do underlying, rule out underlying patent foramen ovale and all the causes of stroke in young by doing
Yes,
a trans-esophageal
actually,
echocardiography.
we have evaluated everything for this patient, though we got that cervical rib, extra cervical rib, which can give rise to subclavian thrombus, and that can dislodge. That is one possibility, but we have evaluated as a young stroke, and we rule out vasculitis,
And
cardiac cause, everything we have ruled out.
Surprisingly, this patient does not have any other features of cervical rib like arm pain and all that thing.
Nothing, sir, nothing. We asked multiple times, but she said no. This is the first symptom that she presented to hospital. So
did you do her nerve conduction studies?
No, sir, I didn't.
We should cervical rib, so we should do that also. This is another interesting thing, that people who are having neurological symptoms of cervical rib usually do not have vascular symptoms, and those who are having vascular symptoms usually they do not have neurological symptoms. So that is why your patient had vascular symptoms, but he doesn't have any neurological symptoms.
Okay.
That's also been mentioned. So very nice, and I think Dr. Badole, any comments, or Dr. Bilala, all young neurologists, any comments, or anybody supporting?
Sir, so some case reports are there. Unusual case of cervical rib with stroke.
Yeah.
I think this is thrombosis of subclavian artery. Cerebellar, okay. But it is a posterior circulation.
Yeah, that is interesting here, that you would expect it in the subclavian artery, but here it has extended and gone into the carotid circulation and gone the anterior circulation.
Yes.
That's what.
Yes, sir. In
So
this
you
case,
must
there was
you
both.
must publish it.
Yes, definitely.
Yeah, in this case there are both. Yeah, it's a both.
Yeah, this is posterior circulation, and
Both.
both are there. Okay, okay.
So any other point?
Can you share the carotid Doppler report?
Yeah, I'll share. I'll share on I think WhatsApp. I have to get it from. I'll just check on.
I think he is disconnected.
Is disconnected?
Yes, sir, he is not visible.
Can somebody call him?
Sir, once there was one, I want to share one experience.
Yes.
Once there was one both lower limb weakness patient, and I was in doing residency that time. And normally MRI is showing some uh, slightly diffusion restriction like thing in ACA territory.
Okay.
Normally in diffusion, bilateral ACA are slightly more restricted. Like normally it is not there, but it looks like. So during that time, I was not having experience. So I thrombolized that case and it improved also. But the next day, my consultant was saying it was not an infarct.
Then what was it?
Don't know whether it was a TIA or what, but patient improved next day. Both lower limb power improved. And spine also we have done. There was no abnormality in spine.
Patient had a acute paraplegia.
Paraparesis.
And was he having hypertension, diabetes?
Yes, sir. There were comorbidity and around 50 plus patient was there.
No, I mean, clinically, it's still the stroke. If it's acute onset paraplegia, it's still a stroke. Could be a spinal stroke or it could be a brain stroke. So I think you did the right thing. Thrombolize it. Spinal strokes also can be thrombolized, and you don't. And there are sometimes some strokes which are diffusion negative. 2% of all strokes are diffusion negative. Therefore, in stroke, we have to go by clinical. And we are even allowed to thrombolize the mimics also. So we should avoid that. But when in doubt, we should thrombolize it. But we must try our best to make a diagnosis. Because if we keep a low threshold, okay, let me thrombolize, can be stroke, then we may actually miss the actual diagnosis. That's all.
Yeah.
So therefore, we must.
So sometimes there is a fear we should not miss thrombolize. That fear should go.
Yeah. That's
so was it something else? So we might have, there is a guilt feel. So we have
guilt feel. So better to thrombolize. Thrombolize later on if it turns out to be something else.
Yes. But that is still there. I think even for me, I sometimes feel no, Jando, let it be. So, and if even for the low NIHS score, like less than 4, many times you feel it may come up.
Yeah, correct. Some strokes may progress later on.
Yes.
That's why we have to take our decision and then talk to family. And I think I'm more biased towards giving always.
Yes.
Whenever there's, I'm more biased, more prone to give rather than not to give. Okay, so who is showing you're showing something? Vishal, you are showing something?
No, sir. I think Shailesh sir is showing something.
Okay, Shailesh. Shailesh, you are showing something?
1 minute. That's one paper I have shown you, sir. The patient were eligible for thrombolysis, but it was not given. This slide was important due to poor functional status, baseline neurodeficits, suspected complex migraine, witness cardiac arrest, suspected somatic symptom, rapidly resolving symptom, and abnormal BP or blood sugar level. This was a good article identifying gaps and missed opportunity for IV thrombolysis in inpatient stroke.
You know, I have written a similar article. If you type my name in Google and say reasons for not giving thrombolysis, you will get our article also there, which we did sometime. And one of the reasons in our study was a lot of patients wasted their time in the busy emergency, where people were not, they did not, patient only did not approach the doctor. He just came, waited in a trolley, and by the time 3 hours were gone. And later on, they realized that they had to thrombolize. Another reason which I have seen in my own practice is that sometimes the patient has a stroke, they have heard my name or name of any other doctor, they want to meet that doctor only. And they wait in the OPD, and rather than going straightway to the emergency. This also I have seen. So there are so many reasons of not thrombolizing inadvertently. That is why this is very important. All emergencies should be very, very sensitive, and irrespective of whosoever is the doctor. So, but I think both cases were extremely interesting. And
sir, I missed one point, that smaller stroke, can we go for thrombolysis or will wait? I missed that point, sir.
You know, the first thing is that in general, you should go for it. Just remember that. In general, you should go for that. There's a story why we are not going for these small strokes. One is when this actual NINDS study was done. In that study, they did not study the patients who were having very minimum stroke. They did not study them. They had excluded them. For instance, patients who were having pure ataxia. For instance, patients who were having pure facial nerve. They had excluded them. So therefore, we don't know what will be their response because they were not part of the study. Second is that when they gave the guidelines, in that guidelines, they said that don't thrombolize the minor strokes. But when they analyzed the minor strokes, they found that they had also done very well. So therefore, there was a general impression among neurologists that minor strokes also should benefit. We should give them the opportunity, particularly because some minor strokes progress. You don't give them, some of them recover, but some of them don't recover. Now, why the cold water was put again on these minor strokes and why you are asking this question and why there's a dilemma is because there was an Indian lady called Pooja Khatri. She is still a very prominent stroke neurologist in USA. And she believed in thrombolizing minor stroke. She very much believed. So she said, I will prove it. So she did a study called PRISM study, PRISMS, PRISM study, in which she took very minor strokes with NIHS less than 3 and thrombolized them. But somehow, for some reason, for some financial reason and all, that study could never be completed. So they had to prematurely close that study. And when they analyzed their data, they found that there was some 2% increase in the bleed of these minor strokes. And you know, in this world of clinical trials and all that thing, it was thought to be it's very dangerous. Therefore, you should never thrombolize a minor stroke. That came from the PRISM study. So how it has translated into the guidelines is that if there is a minor stroke, which is non-disabling, don't thrombolize. But if there's a minor stroke which is disabling, you should thrombolize. Now you tell me, how will you decide whether a minor stroke is disabling or non-disabling? In neurology, it's very difficult. Every neurodeficit is disabling. If you have a severe sensory disturbance on one side, you get an NIHS of 1. That is also disabling for that patient. They have said, no, disabling means if it interferes with the activities of daily living, like shaving, like wearing your clothes. But I'm saying that not necessarily. If you have got a consistent sensory annoyance on one side, consistent burning and pain on one side because of thalamic stroke, that is equally disabling. Similarly, if you have got a right hand weakness alone because of a cortical stroke, your NIHS will be only 1, but it's very disabling. So if you ask me, all strokes, whether they are minor or whether they are minimum deficit, they should be thrombolized. And this we should talk to the family, talk to the attendants and thrombolize them. There is no cutoff below which you will say that, oh, this is a minor stroke. And the other problem is that what is minor stroke with you, after 1 hour, it can become a major stroke. After 2 hours, it can become a major stroke. So it is better to document it there, talk to the family. At the same time, documentation is very important. Suppose, God forbid, your patient will have a hemorrhage. Then he will say, I was having a minor stroke. Why did you thrombolize? So we have to tell the patient that even though you have got a minor stroke, but you have got this deficit, may increase also, and take the consent. Even though everybody may not thrombolize, but I feel that it should be thrombolized if you are okay with taking the risk. Most of the people will give you consent. Some people will not give you consent, and those who don't give you consent don't thrombolize. But by and large, most of the stroke neurologists are biased towards thrombolizing than not towards. What is your personal take on this?
Same thing, sir. Actually, I have came across 2 cases that the minor stroke, but the power was almost 4/5 at the time of admission. I said neurodeficit also not so much, and in fact is also smaller one. But later on in follow-up, they asked me questions, sir, why didn't you thrombolize? I think somewhere they took a second opinion. That time I thought, why I didn't thrombolize? Because it is a stroke. We already all aspects are there. Thrombolysis, there is no contraindication. Only thing was minor stroke. But later on, I decided to thrombolize all the cases except some contraindications. So finally, it is working. But few patients they skip, and back of the mind, I thought, why I didn't thrombolize those patients.
When a stroke comes to you, at that time, you don't know whether he will progress or not. It's a guess which you are making.
Yes.
You are saying it's a minor stroke, but by evening, it may not remain a minor stroke. That is the problem. And by the time 3 hours are gone and 4 hours are gone, and then you cannot do anything. But of course, if it's a very minor stroke, you can discuss with the patient at that time. Look, you have got only facial palsy. It may not progress. And guidelines also are saying you may not thrombolize it, but I feel that we should thrombolize. Then take his opinion and put it on paper and go.
Yes.
Many of them will not progress, but some of them may. That is the problem.
Also, sir, large vessel stroke also, before going to MT, I prefer IVT.
Yeah, that is true. That you said already. So yeah, thank you for showing this paper. This was by my PG, Lalita. She is now in Care Hospital. So this was our paper, Factors Influencing Non-Administration. You can go to the chart. There must be a chart. That's interesting. If you go to second or third page, very interesting. Next. Yes, so these are the factors responsible for non-administration. Massive infarct. No, these are unavoidable factors. Means they came to hospital, but we did not give them. They came within 3 or 4 hours. One was massive infarct. One was hemorrhagic infarct. One was GI bleed. One was oral anticoagulant. One was recent surgery. Obviously, you would not give in those patients. But avoidable was lack of affordability, fear in the patient and fear in the doctor. Both can sometimes be. Rapidly improving symptoms is one more thing. Actually, patients should have completely improved. Don't go by rapidly improving. Initially, we did not know. We were also learning. So it says, sir, patient is raising his hand now. Previously, he was not raising, but he is still weak. He may be raising the hand, but his grip is still weak. He should have recovered 100%, normal. Then you can withhold. But if he has only shown mild improvement, that is not. Mild stroke is also, it should not be a contraindication. Delayed neurology referral, I am seeing all the time. I mean, patients come to the hospital and then they say, no, we have to see this doctor. And they wait for that doctor till the time is gone. So I think this is a very interesting topic. And I'm sure it is happening similarly in all the hospitals. And so we have to tell the emergency people, we have to make them very, very stroke sensitive so that we can immediately take that. So I think we have finished our time. It's 9 o'clock sharp. Dr. Bilala, if you have any point to make or anybody else, then we can. Otherwise, we have to close it ourselves today because our organizers have gone for some meeting. They are busy. So if there's any chat box or anything you want to say, Shailesh? Any other point?
No, sir. We have covered almost everything, I think.
So, okay. So, Saurabh? Saurabh is also not making any comment. And there are no questions in the comment box. And Dr. Subhash, that's Saurabh only. I'm not seeing anything in there. Vishal, no point, no other point. Anyway, yeah. I think it's 9 o'clock, so we can call it a night.
Yes.
Okay. Thank you.
Good night.
Thank you. Thank you, sir. Thank you, sir. Thank you very much. Thank you very much for the great case. Hi, Bilala. Hi.
Yeah.
Thank you. Thank you, sir.
Yes.
Good
Nice.
night. Good night. Good night.
Good night. Good night. Good night.